The theoretical content of this thorax is we already have started the dissection, and it is going at a good pace, I would say. Now we learned this particular space which we have exposed today in the dissections about this particular space. We call them as pleural space and midline space, mediastinum, and we agreed to subdivide this particular space based on some imaginary line drawn from these sternal angle. We call this as a angle of Louis, and we split it into two part, above and below, which is the superior mediastinum, inferior mediastinum. Inferior one, because of the centrally placed heart with the covering, we call them as pericardium, splits this particular inferior space into three spaces: anterior, middle and posterior. We call them as anterior mediastinum, middle mediastinum and posterior mediastinum, which is basically addressing the lower or inferior mediastinum. So this is what we learned, and this particular mediastinal space, we talked about the superior one. We learned about the boundaries, which is limited above by this inlet of the thorax, and then we have this imaginary line at the bottom. Then anteriorly sternum, back side we have this vertebra, on the side we have the pleural cavity, placing and squeezing this particular narrow space, and this particular space is occupied by some structure, superior mediastinum. Content wise, we learned about this particular midline content, which is thymus, which is absent. We have seen that truly existing. The thymus is absent in adult content. So whenever you have done this particular visceral dissection, three of the visceras or three of the thorax you have dissected, none of them have this particular midline structure thymus, because it's a predominantly pubertal, pre-pubertal structure. Before it reaches to like a first decade of life, it is replaced by the fats and largely gets absorbed. And then we see this particular number of big vessels which is coming on here. Superior vena cava, brachiocephalic vein, arch of aorta, trachea, esophagus will be on the back line positions, which is present as a content of the superior mediastinum. And there will be nerves like the superior one will be the phrenic nerve, deep lying nerve. Posterior to this particular root of the lung, we will be seeing the vagus, and the branches of the vagus, we call them as recurrent laryngeal nerve, will be present. And farther deep will be structure like the thoracic duct, and at the lower level we will be seeing some vessels as well, lymphatics likewise. So this is we have talked about so far about mediastinum. Now talking about the inferior mediastinum, we divide this particular space by placement of the heart. Anteriorly it is bounded by the sternum, and back side it will be limited by this pericardium with the heart. It is a kind of like a narrow space. When you open up this particular chest wall, we see this particular space have got some ligaments which we have to cut through to clear this particular thing. We call them as pleuropericardial ligament. Apart from that, this is packed with the fats which we have removed, and we have a midline vessel running on posterior side of the thoracic wall. We call them as internal thoracic artery. We dig that internal thoracic artery out, which is going to branch this particular into like intercostal bracers or mammillary branches. And this particular interthoracic artery and this particular intercostal or anti-intercostal branches are important for us. The reason is that it can be taken as a graft if we have to create some arterial bypass graft for the big organ surgeries, etc., etc. So this particular anterior mediastinum has this particular space which is present. Now coming to the middle mediastinum, which is occupying the most of the spaces in this particular region, having this particular heart with the chambers and the big vessels, and covered with this heart, we call them as pericardium. Now pericardium, we split the pericardium, take this particular heart out, open this particular space, we call them as pericardial space. Once you take these six out, the chambers of this particular heart becomes visible. Though we have a fat layer covering, we call them as epicardial fats, which is present on this particular region. And then we have this particular outlines of these vessels, and as well as this particular chambers of the heart becomes visible. We have the great vessels like arch of aorta, pulmonary trunk will be visible, and likewise we will be seeing these particular grooves which are present between the chambers of the heart. We call them as ventricles, atriums, etc., etc. Now this is kind of like middle mediastinum. Anteriorly it is limited by this anterior part of the middle mediastinum. Posteriorly it is by this posterior layer of this particular fibrous pericardium, and on the sides we have the pleura, which is holding this particular space. Content wise, we will seeing this particular SVC, superior vena cava, arch of aorta, which is arching over here, coming out and making a branch, which is coming from here, three of them. And then we have this pulmonary vein, which is this white one next to it, which is going to the lung, basically from this right ventricle chamber to right lung, splits into two branches, right pulmonary artery, left pulmonary artery, goes to the lung which is going here, and this trachea which is lying little bit backwards. If you just like remove this particular structure becomes visible, which splits into bronchus, right bronchus, left bronchus accordingly at the level of the sternal angle. And then we see this phrenic nerve of course running down, which we have tagged and separated out for doing the dissection, assuming not damaging the phrenic nerve, which is having a long course going down all the way to the diaphragm eventually to supply this. Now this particular middle mediastinum, reaching from there we will be going to posterior mediastinum. If you remove this heart, if you remove this particular pericardium, then only we see this particular part, we call them as posterior mediastinum. We have to cut this particular fibrous pericardium, then we will see to interior or posterior to it, which we are going to do in this dissection sessions. So space behind the pericardium. So if you remove the heart, which you are going to do next day, you have to cut the heart out, then you see the pericardium posterior layer. You cut the posterior layer of pericardium, you strip these things off, and then you go to the back side of it, you land up into this posterior mediastinal space, which is having a space there. So heart is a big structure which is like occupying it, having the ventricles. The posterior mediastinum is having some kind of spaces which is existing. It has some spaces in the posterior mediastinum structure. What lies over here is that the structure which is lying on behind. So this particular arch of aorta or ascending aorta which is arching and going back, then it changes the name as it drops down. We call them as descending thoracic aorta. The descending thoracic aorta moves backwards. That's why it is a structure of backside or posterior mediastinum. We will be seeing this one. Then after this we will be seeing this particular food pipe which is present to it. We call them as esophagus, which is a collapsible structure which is present in this region. So esophagus, surrounding the esophagus we see a nervous network which is present. We call them as plexus. Plexus around this particular esophagus, we call this as the esophageal plexus of the vagus and the sympathetic nerves, which you will be seeing here. Now even though we remove everything out, heart, lungs and everything around, we take this particular chest wall on the back side. So in the posterior thoracic wall, if it is removed, we get this particular structures like that. We have the veins which is present in here, a vein which is climbing on the left side, right side over here you will be seeing, and ending on the superior vena cava, we call them as azygous vein. This is your exam tag as well. We tag this particular azygous vein. So this particular azygous vein, along with that we find a wide structure which is known as going down right side, left side, we call them a sympathetic chain or sympathetic trunks. So these are the contents of it. So you have to memorize what content exists on these individual mediastinums, anterior mediastinum, middle and the posterior one, and likewise the questions will be given in like divide this particular mediastinum based on different subdivisions and give a narrative on this content, whatever the things is lying in X mediastinum, maybe middle, maybe anterior, maybe superior, maybe posterior. You have to write the content of it, giving a schematic small diagrams which is lying in this particular content is concerned. So this is about this mediastinum, and talking about this contents of the mediastinum, these are the whole things which is present in here, and you have to place it according to mediastinum where it is, like where the thymus, where you see brachiocephalic vein, etc., etc. So we will take this each of this particular thing one at a time. Thymus, we just like talked about it. It's present in the young ages before the first decade of life. It was there, then it is replaced by the fat and eventually gets evaluated, and involutions or absorptions of this particular content is there. Now coming to this particular vein which is important for us, we call them as brachiocephalic vein. Right side we have right brachiocephalic vein, left side we have left brachiocephalic vein. Now we have to follow this vein formation, how this particular vein is formed. You see this side, this is a brachiocephalic vein and this blue one is brachiocephalic vein. These are the two brachiocephalic vein, right side and left side. You see this left side, the formations is pretty much clear how these things are formed. You see a vein coming from here. This is a vein, we call them a subclavian vein. It is coming from the arm. Like axillary vein continues here to become the vein, we call them a subclavian vein. A vein coming from above, from the neck region, we call them as internal jugular vein. So these two veins joins together makes an angle, we call them as venous angle. So this particular venous angle, after that we have a vein formed over here. This vein we call them as brachiocephalic vein. So brachiocephalic vein of this one is the left side, and this one is the brachiocephalic vein of this right side. Now right side brachiocephalic vein, left side brachiocephalic vein, again they join together, give rise another vein, we call them as superior vena cava. So this venous formation matters, and how this particular formations is formed, you will be tested in examination, you will be asked in examination, and you will be, without fumbling, you should be able to answer this pretty basic stuffs about formations of this brachiocephalic vein. So right side brachiocephalic vein, left side brachiocephalic vein unites together, forms this particular superior vena cava. But before that, these formations or formative tributaries, and the point where these particular veins are formed, like the internal jugular vein coming from the neck. So the internal jugular vein coming from the neck and the subclavian vein coming from the arm, eventually making this point where this particular union taking place. This union point we call them as angle, also known as venous angle. In the right side venous angle and left side venous angle. This right side and left side venous angle matters to us. We have a clinical point related to the venous angle. Again, I will be coming back to the venous angle, referring here what is the venous angle, how these things are there. So this particular brachiocephalic vein on this particular left side is crossing over the big vessels, like which is coming from the arch of aorta. You see that covering over here. You will be, we cannot see these particular branches of this arch of aorta properly unless until we cut this. You cut this brachiocephalic vein, then you can see these particular branches will be coming deeper to it. This is what we talked about superior vena cava. Right side and left side brachiocephalic vein joins to form superior vena cava. Superior vena cava itself is a short note about the formation. It forms how the union of the right and left brachiocephalic vein on the right side of the mediastinum or right side of this particular sternum at the level of C1 costal cartilage. So this union takes place at the level of C1 costal cartilage, and it drops down to this right chamber of this heart, which is known as the right atrium. It drops down and where it ends over here. So here to here is superior vena cava. So length of superior vena cava is roughly 4 or 5 centimeter maybe. So this particular union point where this particular thing is formed at the level of C1 costal cartilage, where it ends, which is C3 costal cartilage. So between C1 costal cartilage to C3 costal cartilage, this is the entire length of the superior vena cava. So you have to just like narrate this particular, how this particular superior vena cava is formed. Where it is formed, the level second costal cartilage, it is receiving a vein, we call them as azygous vein. We will be seeing this azygous vein which is draining into this particular superior vena cava. And this particular superior vena cava is ending on third costal cartilage on the right side of this mediastinal spaces, and it is draining the blood whichever it is coming from the neck, arms, right side, left side, and part of the chest wall or thorax which is draining into right atrium. So this is about this superior vena cava, how it is formed. You have to prepare this for a short note, keeping a schematic small diagram, how it is formed, how it drains, and the clinical thing will be coming about it. Now next content is aorta. We split this aorta into 3 segments. One part, or the first part of the aorta, we call them as ascending aorta. Then we call them as arch. It is curving. We call them as arch of aorta. Then it is curving on the backwards, or it is not curving straight right to left. It is curving anterior to posterior. So it is moving backwards. So that's why this particular thing which is moving backwards and going on down and going down here, we call them as descending thoracic aorta. These are the 3 different parts of this aorta. So in these 3 headings, we have to learn this aorta. Say first example of this part aorta is ascending aorta, which is covered by pericardium basically. If you do not remove this particular pericardium from here, we cannot see this. Once you remove this pericardium fibrous on, then we can see this particular beginning part of this aorta. We call them as ascending aorta. Ascending aorta has a beginning and has an end. It begins at the half or level of the third costal cartilage, which is lying there, and ends at the second costal cartilage. So it has a small narrow strip region or length which is roughly corresponds to the 5 centimeter, is a great vessel coming from the left ventricle chamber. So which is basically climbing, we call them as ascending aorta. This particular ascending part at the bottom or at the beginning has a dilatation. So we call this sinuses, these dilatations which is present in here. We call them as aortic sinuses. We will talk about aortic sinuses when you talk about the viscera itself, you will be seeing that. Now this particular ascending aorta, as it is climbing up and running or covered by this fibrous pericardium, has a length. This particular thing splits into or gives 2 branches which is coming from here. we call them as coronary arteries, right coronary artery, left coronary artery, which supplies the entire heart. So, this right coronary artery and left coronary artery goes to the right side of the heart, left side of the heart, supplies the entire thing of the heart. If these arteries are blocked, then we have to do some surgeries related to it, like bypass surgeries or like some kind of like a balloon surgery, etc., etc. We will talk about that thing when you talk about the coronary circulation. We will have a special class on coronary circulation that matters, covers a lot about it. So, this ascending aorta, this particular beginning part, again ascending aorta itself is an exam short note. Again, we do not ask you to just prepare a great story about it, just should be able to give some briefing about these things and with a schematic nice presentations about this particular ascending aorta and what are the features that is going to see. What thing we forget about ascending aorta is this, the branches which are coming from aortic aorta, which is the important branch which is going to supply the entire heart. If these arteries are knocked out or if it is problem having with clogging or something, we are in big trouble. So, all these AMI or acute myocardial infarctions or cardiac strokes or whatever the cardiac issues are there, it's because of this clogging of these particular arteries. So, this particular clogging of the arteries is because of this poor blood flow going through it. So, this arteries is a branch of ascending aorta, that what we forget about it. And in an examination we repeatedly ask this question. Having said that, sitting out here in a cozy place where right now you feel like, oh, I understand everything, I remember everything, I give you like a 1000 rupees bet about there will be 100% inaccuracy in answering this in examination. Whenever you ask in examination, we hardly get or 0% result about the where from this particular coronary artery branches are coming from, and it is written. Last time also I put this bet on. So, if in examination if you can answer with 100% accuracy like where from this particular coronary artery right side left side is coming, branching from where, I will give you 1000 rupees. It's a bet. And you see that what I didn't get that bet back. Neither just like you can answer, neither I get my money back. Anyways, so ascending aorta. From the ascending aorta, we move to this aorta part, we call them as arch of aorta, which is arching. Now remember, this arching is carving. This carving is not right to left. It is anterior to posterior. That means it's moving from the sternum to vertebra. This orientation matters to us, how this arching is lying. It is anterior to posterior curving. Again, this is an exam short note about arch of aorta. Now, beginning of the arch of aorta and end of the arch of aorta begins at the same level, like second costal cartilage on the right side to left side second costal cartilage, and the direction is anterior to posterior. So, it begins at the second costal cartilage here and then arching back ends at, before it drops down, then becomes the descending thoracic aorta. So, this particular arch begins at second costal cartilage, moves back here and ends here at the same level second costal cartilage. So, it's only thing, it is on the right side, it is forming, and moving back it is on the left side of the vertebra or left side of the costal cartilage. So, this particular costal cartilage right side and left side you should be able to identify. Why? This is your exam region where you start counting the ribs. We give this particular arch of aorta to draw that in cadavers, that is known as the surface anatomy. In a surface anatomy, again there will be 100% accuracy that you won't be able to draw this particular thing, where from it is beginning and where it is ending and how this direction is coming. No matter how tons of times we tell you about this particular beginning and end of the arch of aorta and it is anterior posteriorly directed, not sidewise, you cannot draw it. So, it is a simple fact, it is proved. You can disprove it by just like doing some good work during examination, only when we can believe that you understand something, or else we see that it is like a impermeable brain which I am just talking to. So, again the beginning and the end of the arch of aorta, second costal cartilage to the right side and end at the same level going on the back, beginning and the end same level anterior to posterior which is directed, second costal cartilage right side and second costal cartilage left side. And again it lies in the superior mediastinum because it pops up in this particular region and it throws out three branches right to left. These particular branches you have to remember. So, branches which you are seeing here right side most, which is brachiocephalic trunk, then we have the left common carotid and left subclavian artery. Now, during doing dissections, you may not be seeing these particular branches very well. Reason is why? Because whenever you are cutting this in the thorax region, we make a low cut. So, we do not cut this particular thing as where it is you are seeing here is going to the root of the neck. Reason is that we want to preserve the content of the neck while we doing these dissections. If you cut this high up, the neck contents or neck muscles will be destroyed. So, in this cadaver we cannot do this particular neck dissections. So, these particular branches will be visible of this arch of aorta which is coming here when we do the dissection in the neck region. When we split this neck region, then these particular branches become visible and you can see that. Till that time, we have to just like take this particular organs or viscera, see this particular heart, and when this particular heart chamber is you are seeing, then we can see on the arch of aorta, of course, brachiocephalic trunk, left common carotid and left subclavian. And this you have to take in sequence, right to left or left to right in the sequence you have to mention how they are placed. So, this branches which is coming from the arch of aorta and this particular arch of aorta in the position beginning end, and this particular little significance about this arching which is lying here anterior to posterior matters to it. From this arch of aorta, this particular diseases of the arch of aorta, sometimes this arch of aorta may be dilated like this. We call this dilatation as aneurysm. So, this aneurysm or swelling is there if it is moving on the posterior side, lying here behind it is the esophagus. It compresses the esophagus, and as a result of that, this food material cannot be going down easily, and patient will be feeling pain when they are swallowing because of the pressure or throbbing pressure of the dilated vein, like a dilated arterial like this. We call them as aortic aneurysm. So, we call this as a dysphagia or compression of this esophagus because of the aortic aneurysms. So, this is about little bit about aneurysm. Do not have to worry or bothered about this aneurysm, the disease, because we do not ask about this. Why we place this particular aorta aneurysm? For this, to understand dysphagia, to understand this correlation of the structure lying on posterior to it. Posterior to this particular arch of aorta is lying esophagus, which is a structure or content of the posterior mediastinum. So that we remember this particular thing whenever we are studying this particular posterior mediastinum. Now, talking about the lower third part which is known as the descending thoracic aorta. As this arch ends, it drops down on the back side or posterior mediastinum. So, it is continuation beyond this particular sternal angle or the vertebral level of T4, then it drops down in the posterior mediastinum and drops down throughout the course. So, this particular thing we call them as the descending thoracic aorta ends once it pierces through or passes through the diaphragm at the level of T12 vertebra. So, it pierces the diaphragm and enters to the abdomen, and then it becomes abdominal aorta. So, this particular descending thoracic aorta sends or gives some branches. We cannot remember all of them, but the thing is that this particular branches which is coming from this particular arch of aorta is that these branches we have seen. These are the intercostal or posterior intercostal arterial branches. So, you see that this particular posterior intercostal arterial branches which you have learned in the posterior intercostal space or intercostal spaces, which is given from this particular descending thoracic aorta. Along with that, it gives some branches to esophagus, we call them as esophageal branches. It gives some branches to the mediastinum, we call them as mediastinal branches. So, this is about this particular descending thoracic aorta. When you tag that in examination, we ask about this particular artery or different parts of these arteries. Now, talking about this branch, we call them as vagus. We haven't studied or haven't exposed this particular vagus yet. Maybe in the next part we will be seeing. This vagus is a content of the posterior mediastinum. Vagus is a nerve, right side, left side, comes from the neck, goes all the way to abdomen, going or passing through the diaphragm and reaching here. Now, one peculiar feature about this particular vagus, right side and left side, it sends a recurrent branch. That means as the vagus goes down, hangs down, it sends a branch which climbs up again and moves back and goes to supply something back, which it has forgotten to supply. So, these branches we call them as recurrent branches. That means it is recurring back. So, as the vagus dropping down from this particular neck region, climbing to this particular region at the level of thorax, this particular branch goes up and goes to supply this particular larynx or voice box. So, this branch we call them as laryngeal branch, and as it is recurring back, we call them as recurrent laryngeal branch. Right side, right recurrent laryngeal, left side, left recurrent laryngeal branch. So, these branches of the vagus is kind of exam important whenever we are seeing it, but this particular branch, as you see that this particular right side and left side hooks into different vessels as it is recurring. In the right side you see that it hooks below this right subclavian artery. In the left side it is arching or hooking below this particular arch of aorta. So, the level of recurrence or where from it is looping back is different on the right side and left side. So, it is a different level recurrence is there in the right side and left side. There is a reason why this is different in right side and left side about the recurrence over here. But the point is that this recurrent laryngeal nerve supplies the larynx and it is recurring back, which is a branch of vagus. This much of information if you remember, that is good. Rest of this recurrent branch everything we will talk about in neck region when study this particular voice box or larynx. Now, other thing which we are left with is trachea. We know about this particular trachea, which is a continuations of this larynx or voice box, which is starting from this particular cricoid cartilage. This cartilage, this is a thyroid cartilage where you can feel this in this front of the neck region, which is known as Adam's apple, which is palpable. Next to that thyroid cartilage, this is the thyroid cartilage on the larynx. Next to that we have this cartilage, we call them as cricoid. So, below the cricoid we have the trachea begins, which is down there and splits here into right bronchus and left bronchus at the level of sternal angle. So, this particular trachea which is dropping down from this region begins at the lower border of larynx below this particular region cricoid cartilage and ends at the sternal angle, splitting into two branches. So, roughly length about 16 to 20 centimeters depending on the height of the individual. Now, it is covered or plated with a cartilage, we call them as tracheal cartilage. This tracheal cartilage is having a look or texture like C. It is incomplete posteriorly, which is replaced by a muscle which is known as trachealis muscle. And this bifurcation point we have a different looking or V looking tracheal cartilage, we call them as carina. So, this carina is the end cartilage which is present in the trachea, which looks like a V over here. So, this carina is just projected downwards and inside as well you see that this is the inside the cavity of the larynx which is seeing through the camera which is known as laryngoscope. So, the camera is dropped over here and inside of the lumen of this trachea is visible like this, and you can see this is a trachea and it is splitting into two lumens right and left. This is the bronchus which is seeing here, and this midline partitioning cartilage we call them as carina. But anyways, this is a trachea which you have to learn about, and we have a class about trachea. I just do not want to talk about. Esophagus, which is little bit I will want to talk about, which is a food pipe starting from this particular lower end of this particular pharynx and it drops down to this particular neck region, and then we have this entering to this particular through the thoracic inlet, enters to the mediastinum. It reaches as the content of the posterior mediastinum. It do not have any cartilage, it is muscular tube, that's why this is remaining collapsed, and it reaches to this particular abdomen, piercing through this particular diaphragm at the level of T10 vertebra. So, that where from this particular esophagus pierces from the thoracic space to the abdominal space, that matters to us, that what you have to remember. Now, this particular esophagus which is having a length of roughly about like 45 centimeters, individual 10 to 45, which is individual variance is there, having a muscular hollow tube which is present in here, having got some kind of constrictions of presence. So, as this particular esophagus there it is going down through these particular spaces, it is encountering some of the overlying viscera. As it is encountered by some overlying viscera, either they are crossing or pressing on, this particular esophagus have got some narrow spots or narrow regions. So, this particular narrow regions of the esophagus we call them as constrictions of the esophagus. We have to know at the levels where this esophagus having constrictions, which is narrowing, which is naturally present. We call them as physiological narrow points of esophageal narrowing. So, we have a point where this esophagus begins and this pharynx ends. So, we have the mouth, then mouth with the oral cavity, then oral cavity we have the pharynx, then after pharynx we have the esophagus. Where the pharynx ends and where the esophagus begins, or esophagopharyngeal junction, with the junctions of esophagus and the pharynx, here we have a narrowing number 1. So, second narrowing is that you see the trachea which splits into bronchus and right and left. So, it is left side bronchus, as it is crossing through the left bronchus which is present in here, it has another narrowing, and another narrowing is there when it is crossed by this particular arch of aorta. These are the three narrowings which is present at three different levels. The beginning part as it crosses with this arch of aorta and as it is crossing this particular bronchus on the left side. Then this particular esophagus goes to pierce this diaphragm, goes to enter the abdomen. Then once it pierces the diaphragm, it has the fourth narrowing. So, these four narrowings you have to keep in mind. Why? These are the narrow points. Too early for next day. Oh, okay. So, this particular narrowing, these are the narrow spots where we can have some kind of abnormal thing clogged or blocked. So, for example, a kid swallows something which is known as accidental swallowing. There are some accidental swallowing, some coins or some toys the kids swallow. So, that particular swallowed object are too large and that passes through the mouth which is wider space. Then we have this pharynx which is also wide. Then it goes to the narrow point which is the tube. Now, within this particular tube, it is not having the exact same caliber throughout. Some of the point, it is more narrow than that rest of the tube are. So, these narrow points where the spots, the foreign bodies or these abnormal particles can get blocked. So, if you know where the likely this particular food particle is going to get arrested, it is easier for us to take these things out, isn't that? So, that is why this narrowing matters. If you know the reason, that reasoning helps us to understand the anatomy and the disease likewise. So, this particular foreign bodies, if it is taken, toys or accidental thing, whatever they have consumed, it can block, it can get stuck at this particular narrow point where it begins. Next point, it can be blocked at this particular crossing over of this arch of aorta and then crossing over this particular bronchus which is left side and then this particular junction point. If they are passing through all of them, they are going to reach to the stomach, which is a wider lumen. So, we have some spaces there direct with. So, whenever we have the foreign objects swallowed, these are the spots that we will be looking for where these particular things are blocked and then we can pick these things out by doing endoscopic procedures, etc., etc. So, this is why we know we ask about the narrow spots of the esophagus or how these particular narrow spaces are determined. This is why we ask you about the crossover where this is. The exact length from this particular teeth is measured 6 inches, 9 inches, 11, 16 inches. So, this inches you do not have to remember. You have to know this particular where it is narrowed 1, 2, 3, 4. And out of this 4 narrowing, which is the narrowest most, that also you have to know. So, out of these 4, which is the narrowest one, you have to figure it out. I am not going to tell you. You have to study your books and come with the answer. Out of these 4 narrowing, which is the narrowmost constrictions esophagus has. Okay, that's for you to find out. Coming to the blood supply of the esophagus, in the mediastinum, it is supplied by the mediastinal branch of this thoracic or descending thoracic aorta. So, it supplies to it. So, this part is supplied by this abdominal aorta branches which is supplying, and lymphatics likewise goes to the group of lymphatics. We call them as this lymphatic group as the mediastinal group or posterior mediastinal group of lymph nodes. Nerve supply, this esophagus is supplied by the esophageal nerve plexus. This esophageal nerve plexus is made up of 2 kinds of nerve. One of the nerve is known as sympathetic nerve, other nerve we call them as parasympathetic nerve. Why this sympathetic and parasympathetic we are addressing here? Now, esophagus is the tube through which the food particles drops down. To make this particular food particle to move, we have to have some kind of movement on the walls of the peristalsis or walls of this particular esophagus has to be there. That particular movement we call them as peristalsis. So, that particular thing, that particular contractions of the esophagus helps the food particle to go down from the mouth to the tube to the stomach. So, this peristalsis is run by these sympathetic nerves and the parasympathetic nerves. The sympathetic nerves which is coming from the group of nerve, we call them as sympathetic nerve chain system. We are going to address very briefly about sympathetic chain. The parasympathetic nerve which is supplying or controlling this peristaltic movement comes from the branches of vagus nerve. What vagus nerve? That vagus nerve which is giving the recurrent laryngeal nerve. So, this vagus nerve and this particular sympathetic nerve, they make a nerve plexus around the esophagus. We call them as esophageal plexus. Now, this esophageal plexus moves this peristaltic, through this peristaltic movement, passes the food material from this particular mouth to esophagus to the stomach. This is the simple explanation about this particular esophageal plexus. We will see this particular esophageal plexus if you do the deep dissection. If you are interested, if this all the viscera are removed, you can look for this particular esophageal plexus. They look like lace like pattern, at a lace er moto lage dekha jay, thick, tough, you can tear through. So, this particular nerve plexus, parasympathetic and the sympathetic plexus, they are existing. Likewise, we have the peristalsis. They are opposite to the peristalsis there. We call them as anti-peristalsis. What is anti-peristalsis? Not always the food material comes to the mouth to stomach. Sometimes you need to puke or vomit it out. So, the vomiting is reverse peristalsis or anti-peristalsis. That too is also governed by these particular nerve fibers, right. So, peristalsis and reverse peristalsis, we call them as anti-peristalsis. Both of these particular entities are controlled by this esophageal nerve plexus, which is contributed by two sets of nerves, sympathetic nerves and the parasympathetic nerve. They are not controlled by us, they are controlled by supreme centers, hypothalamus, etc., or higher centers in the brain. So, these things supplies in this region. And this is what we talked about, the esophageal esophageal can easily be compressed by these dilatations of the aorta, aortic aneurysm, or the chamber dilatations of the heart, especially the left atrium, can compress on the esophagus. The patients, whenever have the compression of the esophagus, may have difficulty in swallowing or pain in swallowing when they are taking the foods. That particular phenomenon, we call them as dysphagia or dysphagia. So, dysphagia is a phenomenon where the patient experiences pain while swallowing the food, and this particular passage of the food is also slowly passing through mouth to the stomach. So, this can be happening because of the compression of the esophagus. Now, why this particular esophagus is prone to have compressions? Because the esophageal is a muscular tube. It do not have any tracheal ring like trachea has. So, trachea is rather incompressible because it has some texture or strength or some kind of skeletal which is helping it out to keep this particular tube open. In case of the esophagus, it is only muscular tube, right. So, that is why this particular esophagus is a collapsed tube. It looks like flat collapsed tube. It looks like a blood vessel. Sometimes we just like a aorta and this particular descending aorta and esophagus we confuse it sometimes during examination. Only if you understand the esophagus is compressible structure, then only you can figure it out which is esophagus and which is aorta. Coming to the thoracic duct, which is a lymphatic channel. Now, you see that we have a collections of this particular lymphatic sac. We call them as cisterna chyli. Cisterna chyli is a small sac like structure, just like a few centimeter long dilated sac or pouch. So, this cisterna chyli from here, which is a part contained present in the abdomen under this diaphragm. So, this particular thing which under the diaphragm we have a cisterna chyli, then we have the channel of the lymphatics which is coming up. So, this channel of the lymphatic which is moving up, which is in a green shadow which you are seeing here, we call them as thoracic duct. So, this particular thoracic duct which is starting from the cisterna chyli in the abdomen under to this diaphragm continues as a duct which is moving up on here and cross. Initially it is on the right side of the thoracic cavity, then it or mediastinal cavity, then it moves to this left side, goes on the left side of this esophagus and goes up. So, this particular channel or this particular lymphatic collection thing, we call them as thoracic duct, which is present in here, which having a length of roughly 18 centimeter, and this particular lymphatic channel thoracic duct initially was on the right side of the mediastinum, then it crosses, reaches to the left side. And where does it end? You see that this is climbing and ending here. Where it is ending? Where this particular subclavian vein and the internal jugular vein uniting. This point we call them as venous angle. So this venous angle present on the left side. So this left venous angle, this thoracic duct ends. What are the functions of this thoracic duct? It carries the lymphatics from this abdomen, thorax, lower part of the body, like the lower limb, etc., etc., and this particular thorax wall. So all the lymphatics, whatever it is coming from the upper limb, thorax, abdomen, they are running through these particular channels and ending into the venous angle. So this particular thoracic duct, we can see that in dissections as well, is a beaded collapsible tube like structure, very thin and very delicate. So this chyli, or kind of like a cisterna chyli, which is present in here, continues up and coursing here. What is the function of it? It is draining the lymphatics. On which part of the lymphatics is drained? This shaded area lymphatics is drained. So all lower limb, all abdomen or whole of it, left side of the thorax, left upper limb, left side of the head and neck drains through this particular lymphatic channel or this thoracic duct. Again, thoracic duct is an exam short note. So what is thoracic duct? It's a lymphatic channel. Of course, there are several lymphatic channels are there. This is the largest one. What it does, it drains the lymphatic channel of the body. Which part of the body? This part of the body. Where it is formed? It formed from here, cisterna chyli. What happens here? The cisterna chyli is present at the abdomen under the diaphragm, and then it begins with the tube. We call them as thoracic duct. What happens to the thoracic duct? It has a length of roughly 18 centimeter. Initially, it climbs in this particular mediastinum on the right side of the mediastinum. Close to this particular sternal angle, it switches over, moves to the back side and toward the left. And once it is crossing over, then it reaches high up into this venous angle at the left side and empties this thing into it. So all these channels which is collecting this lymphatics ending into blood system and draining it like this. So this is how this particular thoracic duct is working. By accident, if it is ruptured or anything happens, we have a clinical conditions. We call them as chylothorax. All the chyles or all the lymphatics is accumulating within this particular pleural cavity or the lung. We call them as chylothorax. When we talked about this lungs and the pleural cavity diseases, we will be referring this particular diseases again. So this is about the thoracic duct, how this particular thing which is going, again it is a short note and your exam tag for the examinations. Coming to the last, not the least, about this particular venous channel which you having, again this is your exam tag. We have to identify this particular vein and we will tag this in examination. Azygous vein. The word azygous means don't have any pair or it do not have any counterpart of it. This particular azygous vein which is running on this right side of the body on the posterior side or posterior mediastinal content. Now how azygous vein is formed? It formed by a vein, we call them a subcostal vein, with joining with the vein we call them as ascending lumbar vein. So this ascending lumbar vein and this particular vein we call them as subcostal vein. These things contributes to formation of this azygous vein at this particular under the diaphragm or at the diaphragm level. Then it climbs up in the posterior mediastinum and climbs particular region and empties or ends into the superior vena cava at the second costal cartilage. So this particular azygous vein, how it is formed, who are the tributary veins, right, ascending lumbar, and this particular subcostal vein, they are formative tributaries, they are forming it. What happens there? It enters to the abdomen through this particular diaphragm and then it runs to the posterior mediastinum and then it ends into this superior vena cava arching over here. Before it ends, it makes an arch. We call them as arch of azygous vein. Now this particular azygous vein, as it is arching over and draining here, the drainage point is at second costal cartilage. So that particular landmark you have to like little bit keep in mind. What is the importance about azygous vein? This particular azygous vein is a contributions or continuous is a connection between this particular inferior vena cava with this superior vena cava. So superior vena cava and inferior vena cava is connected through the azygous vein, which can serve as a bypass for these particular tributary veins. Other than this azygous vein, we have this particular hemiazygous vein and accessory azygous vein, which are counterpart of the azygous vein but not like azygous vein. They are present on the left side, accessory hemiazygous and hemiazygous vein. We just like seen this particular accessory hemizygous and azygous veins, but I am not talking detail about it. So this is all about this particular content, and we have a separate class on these particular thoracic sympathetic chains. I am skipping this thing right now because it will it needs more time to talk about, but all the contents of this particular mediastinum you should be focusing, and you will be preparing it accordingly for your exam, practical exam and theoretical exams as well.